Hello, everyone that's coming into the webinar. We're just going to give it another minute and then we will get started. Hello, everyone. In the name of the National Latino Behavioral Health Association, the National Hispanic and Latino Addiction and Prevention Technology Transfer Centers, we welcome you. My name is Cristina Mancebo Torres. I am the program specialist for the National Hispanic and Latino PTTC. Welcome to the second session of a two-part series titled A Cultural Adaptation of Screening, Brief Intervention, and Referral to Treatment for Working with Hispanic and Latinx Communities. I will be your host for today's presentation. Before we introduce our amazing presenter, here are some brief instructions about our event. Here is the information about our grant. You will receive a copy of this presentation so you can read the content at your own convenience. This session will be recorded and archived for future playback. A copy of today's presentation will also be made available. The lines will be muted throughout the presentation to minimize background noise. When we get to the Q&A portion of our webinar, you will have an opportunity to ask questions by clicking the Q&A box, and we will share your questions with our presenter. We will also be asking you to fill out a brief survey at the end of the webinar. This satisfaction evaluation is important to the work we do and provides us with the opportunity to improve our training efforts. A certificate of completion will be sent via email at the end of the webinar. Closed captioning is available for this event. You need to activate your screen by clicking the live transcript button at the bottom of your screen, then choose to show subtitles. We'd like to take a moment and reflect on the power of words and remind you that together we can use our words to create positive change. Here is the TTC network map with information about the Addiction, Prevention, and Mental Health Technology Transfer Centers. Each network is comprised of 10 regional centers and 3 national centers. The network coordinating offices, National American Indian and Alaska Native TTCs, and the National Hispanic and Latino TTCs. Our center has a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. Please allow us to introduce you to our parent organization, the National Latino Behavioral Health Association, or NALBA. NALBA is a nonprofit and is located in New Mexico with the mission to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. NALBA's objective is to provide national leadership on mental health and substance abuse concerns of the Latino community. NALBA's policy priorities are selected capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of behavioral health professionals, funding for co-occurring disorders of alcohol and substance abuse, opioid crisis in the Latino community, and suicide prevention. We also want to take this opportunity to invite you to the 2022 National Latino Behavioral Health Conference, Latino Behavioral Health Equity, Juntos Podemos, on September 15th and 16th, 2022 at the Sahara Hotel in Las Vegas, Nevada. This conference will provide a forum for behavioral health professionals from different areas to connect, exchange ideas, and together explore best practices to attend to Hispanic and Latino communities. I will ask my colleagues to share the conference website link in the chat so you can take a look and learn more about this incredible event we are organizing for our communities. Our team is staffed by Dr. Susie Villalobos, serving as the project director for both centers. Priscilla Giamasi serves as the project coordinator for the National Hispanic and Latino PTTC, and I work as the program specialist for this center. Ana joined us recently, and she is working as the program specialist for the National Hispanic and Latino ATTC. Now it's time to introduce our presenter. Diana Padilla is a research project manager at the New York State Psychiatric Institute Division of Substance Use Disorders, Columbia University Medical Center. She is a curriculum developer and senior trainer for the Northeast and Caribbean Addiction and Prevention Technology Transfer Centers. Ms. Padilla is certified by the New York State Office of Addiction Services and Supports as an SBIRT trainer. She provides intensive technical assistance and implementation support to organizations in a variety of settings who are seeking to incorporate the SBIRT intervention practice to address health, psychosocial, and other concerns related to harmful levels of alcohol and other substance use. Diana, thank you for your availability to share your knowledge and your experience with us. Please feel free to start your presentation.
Thank you, Christina. Thank you to the whole team. You folks are amazing. Thanks everyone for being here. I'm delighted that you've come back. And I want to just get right into it, because this is really building on what we've already discussed last week. And I'm just really very privileged to be here to speak to this topic, and particularly in terms of adaptation for Hispanic and Latino communities. So we are in part 2 of cultural adaptations of SBIRT, or screening, brief intervention, and referral treatment. And one of the things that I tend to do is I stick with that acronym because it's a lot easier than fully saying it completely, but there will be times that I will do that, but there's so much content here that I would love for it to be more of a seamless process and easier for you folks to understand. So where we left it off last Wednesday is that we were speaking to why SBIRT, or screening, brief intervention, and referral treatment, lends itself to being adapted, particularly with Hispanic Latinx communities. And part of it is that it does have components that lends itself to adaptation, particularly for these communities. And so, as opposed to other evidence-based models, you may want to consider what the process is in terms of identifying a potential intervention to actually adapt. And I'm not really going to go into it too deep as how that process works, but I'm going to give you an idea of a process that you can engage in to consider SBIRT as the intervention or the model, that evidence-based model that you do want to adapt according to your community needs. Next slide, please. So it makes sense to kind of just bring up the strategic prevention framework, or the SPF, from as developed by SAMHSA, and they have a process where a comprehensive approach, rather, that helps organizations to understand the needs of the communities, identify the communities, understand their needs, and help choose approaches or strategies to effectively address the issues presented there. And so these steps that any organization can take almost speaks to what the class standards that I spoke about last week. There is a process that if you want to engage and identify at-risk communities and help to address their issues, you want to know exactly as much details of that community as you can. And then you should be able to correlate that as foundational information to help identify a potential strategy to use. So the assessment piece, which is really to assess community needs, and that's really important because we don't want to use old data. We don't want to use something that's 2 or 3 years old. Considering the last 2.5 years in the environment that we've survived, getting the details of the demographics from the communities that we are speaking to here today, the Hispanic Latino communities, and understanding the heterogeneity within those populations is really key to identifying, what potential interventions are best to work with that community. And so when you identify the community needs and the specific communities and their needs and other characteristics of those communities, you also want to identify resources, and as well as organizations' readiness to be able to perhaps use an approach or identify an approach that you can be committed to actually implementing. And so there's a planning process involved, and then there's an implementation process, and then you want to evaluate your efforts. Any efforts, any type of organizational change, or any type of strategy that you want to incorporate into what you're already doing, you always want to make sure you have a plan and that you're able to monitor its implementation and checking to see how well it's working. And so that's in simplistic terms what this kind of speaks to. Next slide. And so foundational cultural principles. When you're working with any racial and ethnic community, you have to consider these. And when it comes to this population, what I am going to suggest is these two terms. I believe I mentioned them before, but I wanted to speak to it very specifically. Many organizations, federal, state, and local entities use the term cultural competence. I'm going to refer to two other terms in a very specific manner, and it's very conducive to what we're speaking to today. So cultural humility is a reflective process of understanding one's own biases and privileges, essentially speaking to the ability to facilitate introspection, looking at self, values, belief systems, and the more likely that you are to do that, the more likely you are to not allow that to be part of the process of when you meet someone. So that doesn't filter or help misinterpret, things that the other person may be saying or things that they do. And then managing power imbalances and maintaining an other person-oriented stance. And other person-oriented really speaks to person-centered approaches. And so that's perfectly adaptable to when we're speaking from a cultural perspective, with Hispanic Latino communities. And so those components is actually very easy to integrate in practice. So it's much more than just a concept. And they can lead to culturally responsive services. And this is what we're seeking to do. What we want, the end goal really is to ensure that SBIRT can help us, provide services in a respectful and relevant way that is specific to the beliefs and practices, cultural and linguistic needs of diverse communities, and even more specifically, the members of the different diverse communities. Next slide, please. And so, identifying the intervention to adapt. So evidence-based have been typically proven effective with specific populations, whether it's race, ethnicity, or age in the specific settings. And so knowing which population is saying are used in the original study can be very helpful in terms of trying to replicate and adapt it to your communities and within your setting. So interventions should carry the evidence of a positive, statistically significant impact on at least one of the following. But you want to know how effective it's been or what data it has on specific communities. You want to know what the specific behavior it is that it can address. You want to understand, can it be done in different settings? So you want to get those are part of the considerations in terms of researching and identifying a potential intervention to adapt. I will always stress the importance of fidelity. An evidence-based practice is only evidence-based because it is facilitated exactly the way it was designed. And what we're going to do today is discuss how we can facilitate this, just like it was designed, for putting it in a cultural framework and opportunities for culture to be integrated in practices that align and support the different components already inside the model. So fidelity is really important to the degree which your program or practice can be implemented as originally intended and designed to. So the adaptation describes how much and in which ways a program or practice is changed to meet local circumstances. Next slide. So what we're going to do is discuss how the model itself, we're going to go through the model and the different components. This is not an SBIRT training per se, but we're going to at least kind of speak to and review the models and then look at the opportunities where culturally informed practices and Hispanic Latino culture can be integrated here. So part of this is also to consider the differences between the different Hispanic Latinx communities. And that really comes from the assessment of the communities at risk that you are identifying and that you're working with to begin with. And so understanding some of those differences and those distinctions are going to be very, very helpful. And we spoke about in the past webinar, what part of laying the groundwork for today's talk really was about making sure we spoke about the differences and characteristics culturally and with the Hispanic Latino communities, but also the different variations of substance use. In other words, how some communities seem to have a higher prevalence or a higher incidence of certain substance use, as opposed to other communities who might have used a different substance. It really depended and really spoke to the individuality or the individual characteristics of different groups. And so understanding some of that, that is important to understand in terms of adaptation. And so the propensity for the person-centered approach. And we'll talk about it more specifically with the SBIRT model because it lends itself to that. Also, we want to look, what are the points of contact? So we have a whole model here. So it's not just a 5-minute practice that we do when we engage an individual, but it's a broader approach to screening, brief intervention, referral, treatment that provides many opportunities for engagement. And it's in those opportunities for engagement where we can approach culturally and be able to engage and almost partner with Hispanic Latino members, and that's going to be essential for the model itself. And of course, we talked about the efficacy of the intervention. Next slide, please. So to keep in mind, and on another consideration that we must, I'm not going to say encourage, I'm going to say we must take into account, because this is part of the dialogue. This is part of the conversation you're going to have with someone as you facilitate a screening, as you end up having a brief intervention dialogue, or what I call the conversation, and understanding language that is stigma-free is helpful, particularly for Hispanic Latinx groups who may traditionally do not have access to quality care, let alone any care. And so stigma has always been a barrier, within these communities, and access to care has been a huge barrier. And so the language has been identified as one of those things that adds, one of those factors that adds to the barriers. So what we want to do is use language that is supportive. And so that spoke to the slide that Christina had brought up about the language matters. It really is very relevant and essential when you are facilitating an evidence-based practice like SBIRT. And so here, what we have is, and I'll try to mirror this, and you'll understand as we go along why it's very specific. Substance use, we're saying substance use these days, we're not saying substance abuse. Substance abuse tends to be somewhat of a more judgmental term. What we want folks to already to start to feel from us is that we're being supportive of them. If we say substance abuse, a lot of folks already come in when they do enter, when we are able to engage them into care, they do come in with their own stigmatic ideas about what substance use is, and some depletive ideas that makes them feel less than because they are caught up in addiction, if addiction is what their issue is. And so we want to use very specific language. Substance use refers to the consumption of psychoactive substances. It's that simple. We're going to speak a lot to at-risk substance use. And that refers to consuming at levels that result in harmful or hazardous consequences. And so what that really speaks to is when someone is consuming or indulging or drinking a substance, whether it's alcohol, illicit, or prescription medication, that they're using it in a way where they're putting themselves at risk of having consequences. They're putting themselves at risk of driving behind the car and getting caught up and being pulled over for DWI. They may be putting themselves at a risk of using medications or misusing medications, and it's not as prescribed. They're taking more than they need to because they believe they have more pain and maybe they need to. There's a whole array of different situations, scenarios, and reasons why folks may use more than they need to, or are indulging for whatever reason. And there's some folks who are actually living the consequences of that. Someone who just comes out of maybe spending time with friends and they've indulged and maybe step over the curb on their way home. They're not even driving, they're walking, and they fall and maybe they hurt their face, and they end up in the emergency room. There's a lot of scenarios that we don't tend to look at because we're used to meeting people when they meet the criteria of substance use disorder. But I'm thinking about the folks who haven't met that yet. And then you have folks who do consume at levels that they're already experiencing those ramifications of at-risk levels of consumption. And then we have substance use disorder. That is a specific level where the person meets the diagnostic criteria. And you're going to understand why we have specific wording for these processes, because you're going to have an opportunity, if you culturally adapt SBIRT for your communities, to be able to practice this and see why it works so well. Next slide, please. And so one of the things I want you to consider, and so I appreciate that everybody has put in the chat box here, and that's great, because I'm gonna get ready to ask you a question. So, but before we do that, I'm gonna ask, I'm gonna ask you to look at this line here. I have it labeled as Continuum of Substance Use. You can look at the line as if it were, the progression of substance use. So you see all the way at the left-hand side, you see abstinence, you see experimental use, you see social use, and then you see at the other extreme, you see substance use disorder. So next slide, click on the next one. So here what you see is what we tend to understand is there's a lot of people in our communities that either don't use or drink any kind of substance at all, or some folks are able to engage socially and still and then kind of leave it there. Some folks might be experimenting, maybe trying it for the first time or maybe for the second time. And so at this point, these are low risk or no risk users. These are folks that we don't tend to think about having to provide services for. Next click. Most of society either sees someone without any kind of problem or the extreme that somebody has a problem, a substance use disorder. Most of society that doesn't have the information or is used to working with a population like you folks do, they tend to either see either or. And so either somebody can handle their drink or they have a problem, which is the other, the extreme opposite of the substance use disorder. So what we encourage you to start to consider is these folks in the middle. Next click. Folks who are at this level where they have binge use and misuse. So here's my question to all of you. One of my first questions is, so we have wonderful evidence-based approaches and interventions and programs that work for people with substance use disorders or alcohol use disorders. And then we also don't need to provide any really type of services for anybody who really doesn't have any kind of a risk. But yet here we have folks in the middle somewhere or somewhere along the continuum where they may be binge using or misusing substances or alcohol. What do you think? Why do you think the SBIRT model might be helpful here? What's your idea? What's your thought process? Because we're thinking right now we're speaking to SBIRT as perhaps being able to work with the folks right here. Would that be a good opportunity, a bad opportunity? Why? What's the thought? And type it into your chat box. Help bring awareness. That's correct. Thank you. Yeah, we can start to increase awareness. Help people decide to make changes before they reach a level of disorder. That's exactly right. Think about the advantage of being able to have a conversation with someone at this point before they meet any points of the criterion for a disorder, whether it's alcohol, substance, opioid, whatever. So at least provide them the information. It might be easier to have a conversation here than it might be at the other extreme. With someone who has an opioid use disorder or substance use disorder, when we think about the neurological processes that get kind of reformatted after someone meets the disorder, when someone's at that level of disorder, it usually means that they don't have that a lot of their mental processes have been compromised. So it would be easier to have a conversation here and perhaps incite, awareness, raise awareness and incite motivation. So using SBIRT can help us assess tendencies, perhaps identify some underlying co-occurring issues. Could be. We have an opportunity to elicit and engage a lot of information from our folks. To allow conversation in which there's no judgment and allows to generate individuals where each individual is at. don't we always speak to that? How often do we speak to meeting a person where they're at? We're always speaking to that. Well, in our field, in recovery, in prevention, and then from the addiction perspective, we have, and in society, we have traditionally worked with either end of the spectrum. Many people can have that conversation, not even on either end of the spectrum. One of the things that is nice about being able to speak with someone here is that they can comprehend a lot of, they can have a conversation. And so you might have an opportunity to be able to engage someone and not necessarily use judgment and not, I mean, explicitly not use judgment, and be able to perhaps just have a conversation, like a normal conversation like you would have with any other person, and not specifically about targeting an addiction problem or making someone feel like they're depleted in any kind of way. So let me read this one from Angie. I honestly think interventions can work with individuals at any level of use, because I try to move people away from thinking that some people develop addictions and people don't. It really isn't about the individual. It's about alcohol being a substance that we can all develop a tolerance to. I think we live in a culture centered around alcohol, and I like just to bring the science into the equation. Thank you for that. I think science always helps us as providers, always. And so, and it's always good to remind ourselves that on someone's mindset, now that you bring it up, Angie, well, someone's mindset at binge use and misuse may not be at a level where the brain is completely rewired and totally focused on just the substance use. And so that's another opportunity to engage folks. And the other thing is to not forget is that along this line of progression, not everyone is going to get to substance use disorder. A lot of folks just stay consuming at levels at risk, and there's no real predictor who's going to be who's going to lead to a substance use disorder. We may know about risk factors and such, but that's not necessarily a concrete predictor. So there's a lot of advantages, a lot of benefits here. Next slide. So we're going to talk about the SBIRT model. Next slide. So SBIRT itself, all right, it's an intervention model, so it's proven evidence. It's an evidence-based practice, and it's been that means it's had successful, effective outcomes, and it's been replicated in different settings. It was first considered an evidence-based practice in the medical field and healthcare settings, and then it started to be replicated in other settings as well. And so there's so many opportunities here that really it has so much. Despite that it's evidence-based and we have to practice it with fidelity, there is a lot of malleability here, and you'll understand what I mean as we go along. Let's be very specific here. The primary goal of SBIRT is to identify and effectively intervene with those who are at moderate or high risk for issues related to their substance use, to psychosocial or healthcare concerns related to their level of consumption. Next slide. So this is the model, and we just very simply, this is what it is. What I always encourage everyone to know when you start to integrate, when I work with an organization and I provide technical assistance and not just the training, I really provide them the support so each individual and the organization as a whole can incorporate this. It's really important to get familiar with how the model works. And this is very simplistic, but it starts to really give you a nice foundational idea. So the core components, the 3 core components. So the screening process is extremely important. It's a universal screening for quickly assessing use and severity of alcohol, illicit substances, and prescription substance misuse. Please notice the language. So the screening is a process. It's not an assessment. So I want us to be specific about what those protocols look like. Look at this as protocols, as part of that clinical process that a lot of folks engage in when they do meet the criteria. So we know we do screening before we do an assessment. We do an assessment before we do a diagnosis. Here is very specific. The screening, all it does, it looks for a problem. If it finds a problem, then we have the opportunity to explore it. And we do universal screening because we don't want to target anyone. If we target anyone, we can stigmatize folks and we can disorient them and really actually lose the opportunity to engage them in care if they need that. And so screening, it's a wonderful process where you can use a certain type of instrument just to identify if there are any potential issues or problems to explore. Now, if a person has a screening facilitated and there's a particular score, it may justify having a brief intervention. That brief intervention is a conversation that's all geared and designed to just raise awareness, and it's briefly motivational because it incites that, evokes that from the other individual, and it's all to be able to work with folks who are at at-risk levels of substance use. And so working with the screening score, then you're justified in having a brief intervention. Now, in the brief intervention, that screening score might be high enough where a referral to treatment may be warranted. So when we say referral to treatment, I don't want you to take it literally. I know that's exactly where we go to when we look at these words, these specifically identified components. But what I want you to consider that what we do is get a referral for further assessment or specialty care for those with a potential for a substance use disorder. That is specifically written, that is specifically worded to be able to correlate with the specific stigma-free language and the processes. So let's take a deeper dive. Next slide, please. So this is an overall, and this is more from an older curriculum, but it really shows the practicality of SBIRT being practiced in a setting where a team approach can be used. In other words, one person does not have to do the screening, the brief intervention, and referral to treatment if the referral to treatment is warranted. And so it really speaks to opportunities or points of engagement in any particular setting where, for instance, here is a healthcare setting where a person may go to the front desk, and the person at the front desk or the receptionist may give the person coming in for services some paperwork to sign off on, including a screen. Screens can be self-reporting. So many of us know that every year when we go to a physician or any kind of healthcare opportunity or healthcare resource, they typically ask us to update our information once a year. In that information, where patients or clients or members of the community, when they fill it out, that's an opportunity to actually add some of the screening questions. So there's the different points of care, and this, when you get your slides, you'll see how it can go in certain different ways depending on what the responses are. I'm going to take that and show you how that works as we go through the different components. Next slide. Let's start to speak about how culture can be part of this process. Now, we're trying to be familiar with the models itself, the different components. One thing to be very, very inclusive about, very intentional about, it's a better word, is how to build that culturally informed environment. So before you even facilitate any type of intervention, your space, your setting, your approaches should be both physically and cognitively engaging. So the conducive atmosphere for asking the kinds of questions and providing the types of services that we give is to ensure that it's culturally appropriate. So please put in your chat box, some of the potential activities that you could do to make your environment culturally appropriate. And I'm thinking about physically, I'm thinking about different things that we could do. Also, when we remember back the disparity rates, and not just the recent environment, because even before the pandemic, the Hispanic and Latino communities have had a really hard time with, in some areas, with some groups and some regions of the country, have had a really tough time, not just accessing services, but even just, the quality of life has been, it's a challenge for some communities. Being able to keep a job and have living wages is a challenge for some families. So it can be very stressful. Many of the environment is not always accepting. So really thinking about using a preventive approach as being trauma-informed makes a lot of sense. Trauma-informed and culturally appropriate services align very well with each other. So your environment should be affirming. Your environment should be inclusive. Your environment and your approach should reflect the environment as well, where you have the ability to initiate in the first few words your own introduction. Hi, my name is Padilla. I might pronounce as she, her, and ella. Can you tell me how I can refer to you? And I say, and give a big smile and says, okay, so I'm here to, can you follow me to our space so we can start speaking, so I can start learning about how I can help you. It's just a matter of practicing it and being natural with it, being genuine, because how you engage an individual is also, can also correspond with your space, being culturally inclusive. Really important, and we spoke about this before, is the ability and opportunity to ask someone their preferred language. Some folks may know enough language, enough actually English language to get by. Their preferred language may be Spanish. Understanding what dialect is really important, because that really comes from understanding what communities are in your environment, in your catchment area, and that way you're prepared ahead of time. But it's also important to understand that the preferred language can also be, they may speak English, but the comprehension may be very, very different. So understand that communication really involves cultural context, and Hispanic culture is a part of this. And so some folks, and that's a good suggestion. I like that you mentioned that point. Maylin, remember, some Latinos don't make eye contact when they speak, and yes, some Latinos do. So it's really about not making assumptions. It's really about understanding that folks will respond differently to us, and no two people are the same. And there are different reasons for that. And if we're being trauma informed in how we approach folks, we're likely going to be able to engage them. Being engaged or close for privacy, giving them a safe space. Very good, Mia. Thanks so much. That private space is important. Also think about this, because I did this one time when I was doing an evaluation study, and I was working very closely with the treatment course at the time, but I was also working with the treatment facility. One of the things I was able to do is, because I was wanting to use a trauma-informed approach, I also asked them, I said, I would love to speak to you and keep your responses private, if that's okay with you. Would it be all right if I close the door? I also don't know who has had any kind of issues or trauma, so I want their permission to allow me to close the door. And if they don't want that door closed, I'm going to leave it open. So things like that. So normally we want privacy. We want to ensure that they're participating in what that privacy looks like. Next slide, please. Next, and there you go. So some of the elements that you will encounter within your dialogue, within your connecting and interacting with Hispanic and Latinos, will speak to some of the more the terms that we have been identifying traditionally as in specific ways. And so understanding when we suggest to assess your community in your different groups under Hispanic and Latino population umbrella, that's when it's important also to assess for the languages, understand what are the cultural characteristics, because there are distinctions between different groups. And there's also, there's a tendency or some characteristics that members of the communities tend to adhere to different degrees. And so it's important to kind of keep that in mind. So many times, preferred language, cultural context, I refer to that. Latino clients will view a relationship as positive in part when it has elements of being mutual and reciprocal. Western perspective is slightly more colder than the collectivist society the Hispanic Latinos are when it comes to interacting. I would say colder, and I would say maybe colder is not the right word, and I don't mean to offend anyone. Maybe what I say is they're more off-putting, they're more distant. They're not necessarily, they don't necessarily try to be more personalized in interactions. At least not initially when you first meet someone. And sometimes what happens is that relationship or that partnership has to evolve. And so one of the things about the Hispanic Latino community is they value personalism, or what we call personalismo. And so what it says here is an emphasis on politeness, courtesy, and establishing a good rapport with someone. To be very specific, what we hear a lot about is when someone first engages a Hispanic or Latino person, to be personable is to be more friendly. I'm going to use a word that we don't always think about, but this is really important, is for you as a provider to be approachable. So that's a little different from when we are working, say, in a very clinical process where it's more about the process and less about, being very risking being personal with any particular patient or client or consumer. And so what you want to do is actually engage in that manner, because that will help connect with that individual who's there. And so that approachability can help someone else feel comfortable being receptive and being more forthcoming with you with any particular kind of information, which is really, really neat. And it's also in the Latino culture, the terms confianza is really based on trust. So, folks go in and they seek, when they do seek service, when they're at a point and they're seeking service, they're actively seeking services, they're trusting you to have the resources available, the ability to meet their needs. And so that will come out in how you have a conversation a lot of times. For them to feel comfortable enough to be able to trust you and speak to you in that manner, that can be very hugely engaging. And so the idea of confianza, which is trust, and other things like being responsive in terms of respect and trust and dignity. And these are also components of personalism. Personalism also involves not just a respectful interaction, but it also involves being able to, it's also how a person in a community is perceived, is how they're engaged, is how they're perceived and interacted with respect. A member of the community could be very poor and they do their best for their families, and they walk with their head up high because that's who they are, and they do their role expectations, and they're a provider for their family, and they're very proud of that. And so that's all kind of comes in together with that personalism. So we want to be able to not be dismissive when we engage. We want to be able to be more reciprocal. We want to be responsive. We want to be able to engage in a respectful manner. Respectful manner is something that we expect from everyone, but the truth is, it's not just not being rude. Respectful is also about listening information and being able to include those perspectives that you elicit within the process that or the service that you're providing. Next slide. And so let's talk about the screening protocol. So one of the things to remember here is that for SBIRT, we're always encouraged to use a validated instrument. And so I'm going to give you a whole list of the validated instrument, but it's an instrument, it's a tool that's been psychometrically tested, and has reliability in terms of, outcomes in terms of scoring. So a lot of these validated screening instruments are usually, we used to have the NREF website. So I know NIH and SAMHSA do have these websites available. And so we can see a whole list of all kinds of screening tools. What we want to do is ensure that we're using a validated instrument, because the outcomes, the scoring can be are true results. And so there's different types, and it's important that we consider, because SBIRT is a practice that's done not just by clinicians, but non-clinical people, folks who are support staff, different people you do not have to be an advanced level therapist, psychologist, social worker to facilitate SBIRT. So this is really a screening. What you want is a screening that has a scoring process. It should have an interpretation where you can easily detect and understand what the scoring is and what level of risk it may be speaking to, or what level of risk it doesn't speak to. The idea is to understand, is there a potential to explore something? Is there something that's happening here that you may need to explore? So validated instruments, one of the challenges with the instruments that we have today, we're in 2022, and most of these instruments are dated. And even though they have been updated, it's been a while since they've been updated. So the language would be the language that I always encourage you not to use. But it's so important that when we facilitate the screen, if we're doing a person-to-person screen, like an interview session, that we use the word, that we actually reflect the words and ask the questions verbatim. And so the fidelity of the screening facilitation is extremely important. So what we want to do is kind of preface that. Next slide. Here are some, just some of the screening tools that may be used with SBIRT. And then the next slide. So when we're about to do a screening, and we have a screening screening tool that we're familiar with, and some of the terminology is older, and we're trying to be more supportive and more empowering, more motivating with, and using stigma-free language. The opportunity we have here is another one. It's also for to be more culturally informed, is to be able to preface what you're about to do. So when you initiate the report, how you first introduce yourself, maybe you want to use pronouns, maybe you don't, but how you engage, how you smile, how you start to meet them, whether or not you're going to shake their hands, how you develop that atmosphere just between you in those first few seconds is important, because that initial rapport will lead to an opportunity for you to ask questions in a way that's going to be verbatim to the tool. And so you have to kind of set the stage, so to speak. And so you want to be transparent, and you want to be person focused. You want to be able to have that culturally and trauma informed, inclusive, affirming environment. So when you continue to speak, you want to let them know, well, I need to, I would like to ask you some questions. Next click. And you might, this is just a sample of what you might want to say. So I would like to ask you some questions that I ask all my patients. And so what does that say when we say that? Thank you, Chad, for that. So yeah, we're asking everyone. Thank you, Jasmine. And so these questions will help me to provide you with the best care possible. And that's what I want to do, is make sure that you're the focus of what I'm trying to do to help you. So as with all medical information, your responses are confidential. So we're speaking here, yes, and being inclusive. And what we're speaking here to is the reality of, we are trying to keep the confidentiality in it. Want to make sure that that they know that the information is kept, it's kept private. But when you explain confidentiality, explain it very specifically so they understand what that means in your setting, and have them repeat it back to you. And so also let them know, it says, so this is really just to keep it between, keep this information guarded for your benefits. And so the research has shown that has been a really important factor in helping folks feel safe enough to have a conversation of information that they would normally have with other people. And then the last part we might suggest something like, also we can stop at any time, or we can stop when if you feel uncomfortable at some point, we can stop, and then we can start again when you're ready. And so the idea here is, you could say, and part of this is also that the questions I want to ask you might have certain terms on, like sometimes, they might use a term like substance abuse. And what it really means is that sometimes someone has an extra drink, someone might smoke a joint, someone might do certain things. But when we're trying to just ask those questions just to be able to help you, would that be okay? The idea is not to be clear, to be transparent, and let them know that certain terms that they're going to hear is not off-putting, it's not judgmental, but ask their permission. That's really important. Next slide. So this is just an example of one of the screening instruments that we might use. And so I tend to look at this one because this one is not just alcohol, and alcohol and substances. And with the terminology here, as you can see, like if I were to ask all the 4 questions, it would say, I'm just going to read the first one. Have you ever felt you ought to cut down on your drinking or drug use? A lot of folks, drug use, you say the term drug use, there's an instant negative connotation, and they're thinking, oh, you're calling me a drug addict. And that's not what you're asking. So this is why we preface this just before we ask any, for whatever screening tool we decide we're going to use. We want to make sure they know that there's certain words that come up here, but all it's asking is just what kind of, what substances you might be using. If that's okay with you, then I'll ask you. But that way you've already taken the time to explain to them so they're more comfortable when they hear it, and they don't feel like they're judged. And then you will go to, and with the KJ, you will go to all 4. The advantage and the benefit here is a very simple, very brief screening tool, but it has an interpretation. And so here towards the end, what you see is 1 or more yes responses is regarded as a positive screening test. I also want you to consider, within the context of the time for when this was developed years ago, before we started thinking about the importance of using stigma-free language, that's why it's so important to preface it. So 1 or more responsive is a positive screening, is regarded as a positive screening test. It doesn't mean automatically, that means that they need to go to treatment and we have to give them a referral. What it means is it's an indication of possible substance use and the need for further evaluation. because it is in the evaluation that someone might get a diagnosis. But that's not what we're doing here. Next slide, please. So this is what we're doing. And this is why the terminology, the words you use have to correlate. Screening is not providing a diagnosis, an assessment. The assessment piece, when you facilitate that, that usually incurs either diagnosis or it doesn't. But it's that assessment process that would incur that. It's meeting those 2 points of 11-point criteria, 2 or more points of an 11-point criteria. A screening tool is simply looking if there's a problem that you might need to explore further. That's why our language has to be specific, and that way we help to keep them engaged. Next slide, please. So brief intervention, and a lot of you folks are familiar with this. Next slide. This is part of the second component. And so the factors for brief intervention, the one thing I want to make sure that I stress ahead of everything else is that you don't have a brief intervention with an individual unless that screening score indicates that you should. If you have a suspicion, but the screening score doesn't correlate, your suspicion is not a good enough reason to have a dialogue. What you want to do in SBIRT, for the whole model to work effectively, you want to make sure that that screening score indicates that we should have a brief intervention, that they have scored to a level of moderate or risk. And so that's why we want to be very specific about the language and specific about the process. And so essential motivational interviewing skills, many of us are familiar with the core communication skills, which is really relevant to the conversation, asking open-ended questions, reflective listening, affirmations, and summaries, which is kind of like reflective, but just kind of recapping. All that is motivational interviewing is an evidence-based practice all by itself. And it was also considered an evidence-based practice for both Hispanic and Latino community populations, as well as Black and African American populations, because it's such a person-centered approach. So so that's why that's part of the reason why SBIRT lends itself so well to adaptability. So being as an evidence-based practice, and I also want you to understand that here when we're talking about a brief intervention, we literally mean a brief intervention. This is not brief strategic family therapy, which is usually anywhere between 12, 14, or 16 sessions, I believe. And each session can be 45 minutes to an hour, and it's called brief because there are small components. When we say brief here, it literally is. And so initially, when we first started to study this, the researchers had said it was 5 to 15 minutes. One of the things I do know about for organizations that seek to bill for SBIRT in their facility is that you can bill up to 30 minutes for a brief intervention conversation. And so, but generally, very often 15 to 20 minutes tends to be the average of what I've seen in the research, tends to be the average of the conversation, because it's really not that, it's really one based on what the other individual is saying. And there are certain points when you attend the training and you get into how it works, when we take a deeper dive into this component, you'll see that it's all person-centered. It's all based on what you get from the other individual. And so it tends to be 15 to 20 minutes, but it can be shorter, it can be longer. The idea is that you tend to either end with an action plan, the opportunity where the individual kind of identified they probably do need to do something about their behavior, and they can identify what they'll do. Or maybe you need another, maybe you need to meet them again. Maybe at that point, that the individual is not necessarily open to their dialogue, their comments, the words they say are not necessarily reflecting that maybe there's something to look at to do different. So you might need another session. And that's what we call extended brief intervention, an extended brief intervention. It's also brief treatment. There are times where brief treatment can be incorporated, where you meet someone 2 or 3 times, and that's considered brief treatment. And 2 or 3 times for a limited amount of time, and where it can result in a reduction of consumption or substance use. Next slide. And so the brief negotiated interview all by itself was already an evidence-based practice long before the researchers put these three components together. And so what it includes is building the rapport, the pros and cons, information feedback, readiness ruler, and action plan. So what it is you initiate the rapport with the individual, and there's more to it than that. You do have the opportunity to kind of do decisional balancing. If anybody's familiar with MI, motivational interviewing, weighing out the pros and cons. It are strategic skills that you use to help the individual kind of explain away some of the controversies or the contrasting statements they may be making without you leading. That's the important thing. You can't lead. Here is the point I really want to kind of go into very specifically here. So information and feedback is really important. And that's when you ask permission to listen. I have some information about that. Do you mind if I share it with you? And then you share the information, and then you ask them what they feel about it. So here's one point just to show you another opportunity where we can culturally adapt this process. Next slide. Okay, so if it was alcohol, so alcohol has recommended guidelines, and we spoke about it last week. A lot of you were very familiar, which is really great. A lot of you were very familiar with the recommended guidelines by National Institute on Alcohol Abuse and Alcoholism. And they refer to these days more to the dietary guidelines for between 2020 and 2025. And they include 1 drink per day for women of legal drinking age, up to 2 drinks per day for men of legal drinking age. Now, a lot of the tools that are still being used still use the other way of framing it, the older way of framing it, which is no more than 3 drinks in a day for a healthy woman, a healthy average sized woman, or no more than 4 drinks in a day for an average male. And so here's the interesting thing for adaptation. Next slide. Here are the tools. So we are encouraged that when we are having this conversation, we are informing an individual, we're informing especially a Hispanic or Latino person who is not necessarily looking at substance use or their level of alcohol use in any kind of unhealthy way. They still keep a job, they still maintain the bills paid, they have healthy relationships with their family, they do well, they go away on vacation. It's not like they're associating any negativity with their level of consumption, although they may be at risk. And then what you want to do is use whatever kind of visual aids that you can. So this is just one, different states have their own version. And this is one of the versions I use because I'm from the East Coast. And so the document on the right is the brief negotiated interview outline is an algorithm. It says it has those strategic, those strategies, those techniques that I just listed from the previous slide. And then on the left, it has a visual about, levels of risk with alcohol, and then, male and female guidelines and how it applies. The problem here is that it uses a binary perspective. So cultural adaptation kind of depends on who you're having this dialogue with. And so next slide. So, and we have very limited research, but there is some research. And so when we're thinking about, say, transgender and gender diverse community members, when you're facilitating this for a member of this community, then you want to be able to recommend the drinking guidelines. That's what you have to go by. But you have to be honest and transparent. And so what you want to do is acknowledge or recognize that they're developed through a binary perspective and share that with the other individual. Give them their respect and be very clear and transparent and honest with them, and that elicits a better partnership and dialogue with them. And so next slide. So I wanted to suggest, so this is something that we've been incorporating lately in our SBIRT trainings, because when we think about the non-binary population, LGBTQ plus population, we want to be very specific and person-centered. Well, if you have binary, if the tools that you're using are the only ones that you can use, and they're from a binary perspective, how you interact with the individual and present it is really important. And so I have an example here. Let's just say, we are working with a Latina trans woman. Let's say Alicia. Alicia is 23. She speaks Spanish, but she speaks some English. And she scored at moderate risk, and you are about to have a brief intervention with her. And so part of the opportunity, part of the conversation would include to provide the guidelines. How would you do that? Well, maybe we could say this. Lynette, would you like to read this out loud for us? Sorry to put you on the spot.
My pleasure. Experts recommend drinking guidelines for people. Although these guidelines are based on a binary perspective, and if you are all right with it, I can work with you to understand which ones best apply to you. Is that okay? The current recommended drinking guidelines suggest limiting intakes to 2 drinks or less in a day for men, not to exceed more than 14 in a week, and 1 drink or less in a day for women, not to exceed more than 7 in a week. These guidelines are based on male and female anatomy. Biologically, male bodies tend to retain more water than female bodies, and water is needed to metabolize alcohol. That's why there is a difference in guidelines. Which of these do you think might best apply to you?
Wonderful. Thank you so much, Lynette. So this is a potential strategy or approach. So we really had to kind of work with the research here and really look at what is it, how can we engage? If I want to engage with a Latina trans woman, that first of all, I have to make sure that I'm privy to the language, because comprehension is key. I have to make sure that I'm engaging and that I am being inclusive and affirming, but I also have to make sure that I'm transparent. I have to meet her where she's at. And for her to kind of be participatory in her own process, I have to ask her, it's really about what she identifies would be the best guidelines to use with her. That is hugely empowering when folks can feel like, okay, it's up to them to decide, and I will work with what they tell me. And so right now, this is what the research is suggesting. This is more than we've had in a long time where we didn't have any research on this. So we're looking to include these, include non-binary folks in these processes and still be person-centered. Just be clear and honest about the fact this is from a binary perspective, but you can tell me which one it works best for you. And then we can go from there. So thank you for this. Thanks for reading, Lynette. Next one, please. And so the other thing is, what if the next slide, what if the individual speaks Spanish? I translated in Spanish and it's just easy, and that's even more culturally engaging. And it's also, when you're speaking in a very conversational, very approachable tone, you're engaging in a conversation almost like with a friend. Even though that's not a friend, you are using that tone and you're speaking to that person like that. There's no judgment. It's just, collaboration. And it's all about helping them. And if they already know and you're speaking to them like this and you're saying, well, this is what I have, but you can tell me which one do you think is best? Which one do you think best applies to you? And then we'll have a discussion from that. And that is important. The participation and working from what they tell us, hugely important. Thank you so much. Next one. There's also a dialogue here that I offered because we do SBIRTs with adolescents. So you got a Hispanic, Latino, or a Chicano, or if you have a Dominican young man, or maybe she's from Guatemala, and you want to be able to actually understand the language preference. Also, the language here will be the message here will be different, because we don't encourage any kind of drinking. So it's not about reduction. So it's more about, I recommend you don't drink until your legal age of 21, but there's also a way to be very engaging in how you present the information. And then you ask us, so what do you think? And so you're engaging in just a conversation as opposed to, and that what you're having is a brief intervention, but they're feeling a conversation and the message is getting across, the information is being conveyed, and they're able to interpret and come back and participate and be collaborative in that conversation. Thank you, Lynette. And I have a little time. Any questions about that? I know we're going to give you some time at the end. Then one of the things that we want to make sure that you're really clear about is that there are different points where we can be amazingly engaging, that we can be more culturally incorporative, more informed in how we engage, and really specific to the communities we're working with. So whether there's a non-binary perspective involved, whether there is a language involvement, you also want to understand that, and that it might come out in the conversation, particularly when it comes to certain substances, if it's been normalized in the family. If marijuana has been normalized and has been used by different generations in the family, you're going to get that in the conversation. You're still going to work from their perspective, and you're still going to kind of use that decisional balancing approach, that pros and cons, and you correlate that with what their needs are. A lot of times somebody comes in to get services for you to be able to meet a specific need, and it may not have anything to do with substance use. And then the substance use actually starts to reflect itself as a potential barrier to something they want to do. So you correlate that back to their needs and ask them, so how does that fit in? And how is that going to help you or not help you meet your needs? So it's really about a conversation based on what they tell you, and you're still able to provide the information and just get their feedback. Really have them, you said, you get the feedback and you provide them the information. You say, what do you think about that? Out of the two people in that conversation, the one that should be listening more is really you. And the one that should really be talking more should be that person. So that Latino, that Hispanic, that Latinx person, that's a person. And so let's go move on into the next one. So we're going to talk about making a referral. And as you can see, I intentionally left us at making a referral. The component is making a referral to treatment. Next one, please. So a few things to consider here. So many different opportunities. Referral to treatment really speaks to when that screening score is high enough where it justifies having a brief intervention. That conversation can help increase receptivity within that person to consider getting a further evaluation. The reason you can't say, you will benefit from a referral treatment, you can't say that, but it wouldn't be appropriate, because that means that we're saying referral to treatment, that means we're saying that you have a substance use disorder. Nothing in the SBIRT process indicates that we have diagnosed anyone. So the proper language, which also helps in keeping that rapport that you have with the individual and keeping that collaborative atmosphere going, is helping a Latina realize that, okay, so maybe you would benefit, and you could say in Spanish, whatever language, might benefit from a further evaluation. Very different. What do you think? Put in the chat box what you think is the initial feeling you get when you hear you might benefit from a referral to treatment, as opposed to you might benefit from a referral for further assessment or further evaluation. Can you hear the difference there? And if so, what is it? Here versus pathologizing. Less judgment, referring person has already diagnosed me. Yeah, and we're saying that we're screening. So that's helpful for us as provider. It's really helpful for us to process that information, these protocols, in the specific manner it's meant to be. Yeah. So we don't want to mislead a person. Transparency and honesty, and it's always on our part. It's part of our ethical responsibility. So I'm always going to say ethical responsibility when it comes to that, because I can't say I'm going to refer to you treatment if all I'm doing is I'm just screening you, and the screening tool only says, you benefit from further assessment. So the reason the component, thank you. Someone is seeking to understand the client's needs as opposed to jump to the conclusion of treatment. Remember, stigma in language. Language has stigma. We say referral treatment. We're saying you have a problem. Person's coming in not necessarily with thinking they have a problem. They're probably coming in to get help with something completely different, maybe something that has nothing to do with substance use. And so what you want to do is keep that dialogue specific. And so when after having a nice conversation or person-centered, and they're feeling, and maybe they're open, they're thinking maybe they do need to do something a little different. And you can be very clear and transparent and say, well, your screening score also, dictates that you're at a high level of risk for substance use disorder, for a substance use problem. How do you feel about that? And then say, would you be open to for further assessment? And then you've already engaged. Why can't you be clear and honest? Let's say further assessment. Where does that take place? Guess what? It has to be with a professional who has the credentials, as an addiction professional to be able to do that diagnosis, to be able to facilitate an assessment and possibly a diagnosis. So what are you going to do? You will refer to treatment. The thing is, you don't have to labeled or worded that way. But one of the things that I want to stress here is the importance of making sure that where you refer someone, if your organization is wonderfully culturally diverse and very appropriate and linguistically conducive with your communities, that's great. Make sure your resources are too. If they're going to have a different type of experience, you need to know where you're referring someone. Now, remember when I was speaking to some of the cultural elements between the Hispanic Latino community members and values that many of us adhere to, what I would tell you is that when someone is open to a referral for further assessment, then instead of just saying, go to this place and explain it, so well, it has to be done by a professional. It's not out of my purview. It really has to be done with a professional that has the credentials. So they would be at a treatment site. But I can make sure that you will refer to Juan Rivera, and he'd be more than happy to kind of take you, to kind of work with you and, and meet with you and do that process. So here's the thing. When you mention someone's name, know the person who you're referring to. It sounds more personal. It sounds more intimate. It sounds like you know the person. They're going to go off of how they already start to trust you and who you're going to recommend. So instead of just saying, just go to that site, making it kind of like somebody, like just a distant resource that you're giving them with papers for them to show up. It's different when you actually mention the name of the person. And so make sure that organization is also culturally informed in their interactions with the communities. They might ask you questions about being familiar with different levels of care. Maybe these folks are coming in, maybe somebody is very well aware of the ramifications, the consequences that they're experiencing with their level of substance use. Maybe they do know they probably need help. And in that conversation with you, they're open. So what they might do is start asking you questions. Maybe not everybody's been to treatment. There's 2.5 million people that who might come into treatment in any given year. There's more than 20 million people who never come into treatment. So a lot of folks don't necessarily know what happens. So if they ask questions, be familiar with the different levels of care. And so, so cultural matching is important. So understanding that there's some resources that you use are culturally appropriate themselves, knowing that ahead of time is very important. And so also the referral criteria, when I say name of contact, that personalism, they're going with what they trust in you. So that sounds a little bit more comfortable than just giving you a name of a stranger that they don't know who they're going to meet. And so schedule the appointment immediately, and also think about a warm handoff. Do you folks, tell me in your chat box, do you folks have peer professionals, certified addiction recovery professionals, or certified peer surplus, I would say? Good. So here's what's helpful. When we say a warm handoff, accompaniment is so important. If someone is receptive, if you can walk them down the hallway to a colleague, that's great. If you don't have that opportunity on site, then maybe you want to set it up in such a way where a peer recovery professional, I'm a peer supervisor, awesome. A peer recovery professional can meet with them. And so peer professionals are really wonderful in terms of the culturally informed engagement, because if you have folks who represent the community and they have their lived experience, that could be a wonderful conduit for them to be able to engage, be more open about following through on a referral, and then follow up and have them kind of reflect back to you what their experience was like. Always leave that door open. And then, so thank you so much. I'm glad that more and more, there's still places that might have 1 or 2 people. And really what we want to do is have more pre-professionals available. Really, really important. So next slide. So we've spoken about different opportunities, points of engagement, where Hispanic and Latino culture needs to be considered in terms of how to engage, in terms of prefacing the different components that you want to facilitate, exactly the way it's designed, in terms of the dialogue and understanding that some folks might reflect in their conversation how certain things may not be as important, or they might reflect that family is more important. They might not be actually forthcoming with some information. Sometimes the personalism, the dignity, the respect, all of that comes into play in how we engage. And so when we think about all that at different opportunities, and you'll get these slides so you'll see it more clear, a little bit clearer. What I do want to end here with is that when you do these efforts, when you do decide to go in this direction, when you do, please also think about measuring your outcomes. Understand that when you have a strategy that you're going to implement, that you should have some kind of measure. Man, it's something as simple as just like every 30 days after you started implementing within a small the SBIRT intervention, the culturally adapted one, and then 60 days after that, you want to have different points to see how effective it's working. I also want to suggest that when you do decide, because I feel like all of you should decide to do this if you're not doing it already. When you do decide to actually incorporate a culturally adapted version of the SBIRT, to do it in a certain smaller component or program of the organization first. Try it on a small scale and understand how it works. And when you become very familiar with how that works, you can do it throughout the process. You can actually practice it within different points of your infrastructure in the different program deliveries, program services that you provide. And so that makes it more manageable and makes it easier to understand what works, what doesn't work. Because how you facilitate this kind of speaks to, how your protocols, how your operations work. And not all settings are exactly the same. And so this is just a brief, this is a measure of efficacy of SBIRT. There was one organization that looked at different points and different opportunities and different allocations and different items that they were looking at in terms of reduction, in terms of the community, in terms of timeline. And so we included the source there because it may be very helpful for you. But if you can connect with either the Hispanic, National Hispanic and Latino, ATTC and PTTC, and or other resources who have already implemented in their area, work with people who already have this experience that can help you support your efforts to integrate a culturally adapted SBIRT with your Hispanic and Latino communities as well. And so with that, it's just enough time. Let me just give it back to Lynette. Or Christine, I'm not sure. Sorry.
Yeah. So the slide shows the QR code and the link for our satisfaction evaluation. The link is also in the chat and will be emailed out when these certificates are sent out. If you can take 5 minutes to do this survey, we would really appreciate it. This actually allows us to continue providing these types of events for you all. So if you don't get a chance today, I will be sending out the email probably in the next day or two. So you'll get to be the link there as well. So if you have any questions, put them in the Q&A box. It looks like there are 2. Diana, I don't know if you have access to see them yourself.
I do.
Okay.
So I see the question that Carlos put out, and I want to read it to everyone. Stigma-free language, to change the language, for example, Latinos which is the original language to include females to males, everyone in between, to use the term Latinx, which highlights what? So one of the things I didn't do in this one, but I did in the first presentation is a lot of the references these days with researchers, and I don't know what the rationale is, but it's Hispanic Latinx communities. Yet we have a center who's also Hispanic, Latino, ATT, and PTTCs. And so depending on the source, they may use a variations. What I suggest is just be inclusive and just say Hispanic, Latino, and Latinx. There are a lot of people who identify as Latino or Latina. And so leaving that out might be more dismissive and off-putting. So it's, even if you have Hispanic and Latinx or Hispanic Latinos, use all 3 terms. Latinx has a lot to do with being gender neutral because the Spanish language and the Spanish culture is, Hispanic culture is very male dominated. And this is a way, Latinx is a reference where folks can associate their heritage without having to identify their gender identity. And that's not, and I think that's a wonderful thing, not to make an assumption that people have that choice. And so with stigma-free language, see if you can get into the habit of like using them interchangeably and prefacing it, letting folks know, or asking someone, what do you prefer? That would be, I think, the best approach. The next question is regarding language, what difference do you see, if any, between using healthy, unhealthy substance use versus low risky substance use? A lot of the research references reference low risk or risky substance use. There are certain specific categorical type of references for that. And so what I want to say is that low and risky substance use is when the screener tools actually, indicate that in the scoring, where they have either low risk or they come up at a risky level, where at risk, risky or at risk means someone is consuming at a level where their level of consumption can putting them at risk of different situations that they can prevent, like for instance, DWIs or strained relationships, or they're heading in that direction. Healthy and unhealthy substance use. The reason I don't hear that often, and I don't use it personally and professionally, is because the research doesn't speak to healthy and unhealthy substance use. It could be misleading. So is there such a thing as healthy substance use? So, because our population, our communities are not necessarily informed the way you folks are, you folks bring all your expertise, your knowledge, all that wonderful experience, but most of society in our communities don't have that. So if you say healthy substance use, is almost a justification. So I would kind of stray away from that. And that's my suggestion, but you could probably look up more for some more research on that. That's really a good question. I like that. And that was for Jennifer and Luis. Is there a particular interpreter certification recommended for doing these kinds of services, such as bridging the gap or other more specific for working with substance abuse? And I know you mean substance use, because we don't use substance abuse. So I think it depends on where you're at. So I think it depends. So the idea with interpreter services has a lot to do with how they're certified, what languages they're certified, what dialects, and do they correlate with the communities you serve? Are they familiar with the HIPAA laws, with confidentiality laws specific to your setting? And so many times your Department of Health or Office on Mental Health can provide you guidance within your state about that. And I believe, and Christina can tell me, I believe the National Hispanic Latino ATTC can be a really good resource to speak to that.
Yes, definitely. So I think that's all the questions. Just giving it a second, just in case. Those are the references for the presentation. If we were not able to answer a question you had, you can go ahead and reach out to us or Diana. Here is Diana's contact information. Please visit our conference website to learn more about all the amazing things we're preparing for you, including a tribute concert to Selena and Vicente Fernandez. The money raised by this event will actually go to one of our scholarship programs. The conference is taking place on September 15th and 16th in Las Vegas. This concert will be the culminating event for that conference. We would also like to share our contact information. Please feel free to contact us if you have questions or if you need assistance. This is the information for our ATTC. And this is the information for our PTTC. Thank you. Have a lovely week.
Thank you so much, everyone, for being here. Thank you to the team. You folks are great. And you, and I know you're behind the scenes, Victor, but I thank you too.